So let me start by saying welcome to this webinar. It's a topic that I often present on, and some of you may have attended my talks before. It's a very important topic. There's a lot of misunderstanding that revolves around this topic, and hopefully some of those misunderstandings can be clarified this evening as we go through. You can ask questions, as you probably know. There's a question and answer button. If you have a question as we go along, please post that. And what I'll do towards the end is I'll just check that to see what those questions are. And we'll pick at least some of them for me to respond to, if that's all right with you. Okay, so let's press on. So menopause and bioidentical hormones. Let me just start by saying this, that actually I didn't come into a knowledge of hormones or practicing hormones from a menopause perspective, or even for a menopause or andropause perspective. It was really from an anti-aging perspective, because a lot of my work that I do here is from a better aging standpoint. And actually, we've known for many years in the anti-aging fraternity that it's almost impossible to talk about better aging unless you address hormones. So it's from that perspective that I really started to get interested in hormones. And of course, if you're going to use hormones for better aging, you better be using ones which are safe and not causing increased risk over time. That would be the last thing you want to do. So that's what this side is showing, is that as we age, the central control of hormones, the hypothalamic pituitary axis, HPA, degenerates. So we lose control of our sympathetic nervous system and our hormone regulation. This is well known, and one of the theories, I should say, of aging. So this leads to hormonal deficiencies. And here's the thing, this bottom section: the restoration of optimal hormone levels is crucial for treatment of diseases, prevention of disease, and improvement of quality of life. So this idea that we only use hormones to treat symptoms is actually not quite correct when you look at this from an aging perspective. There's lots of other benefits of the hormones that we should consider, and we'll talk a little bit about as we go through this evening. So what do we say? This is what we say. And when I say we, I mean we anti-aging doctors. We say that a normal physiological level of natural or bioidentical hormone replacement therapy, sustained for a lifetime, may be one of the most important anti-aging and health maintenance tools a woman or man can use. That's a pretty profound statement. Now, this slide shows you, it's a graphic, but it shows you the general decline of hormones with age. And what you see there is most of them fall. You can see, if you look at E2 is estrogen in women, and you can see that fall of estrogen is quite abrupt as you get into your late 40s, 50s. DHEA starts to fall when you're in your 30s. DHEA is a precursor hormone. I'll say a bit more about that. Testosterone also falls. That's the T in the graph. It falls in women as well as men. We'll talk a little bit about testosterone in women towards the end. Hormones is a big topic, so I can't cover everything in this presentation, but I'll touch on some things which I think are particularly important. Progesterone, which is not shown on here, which is the other main female hormone after estrogen, and works very closely with estrogen. It's not shown on here, but actually falls before estrogen does as a woman approaches menopause. Okay, so what are the consequences of hormone deficiency? Well, there'll be some of you listening who will be all too familiar with this list of symptoms, but let's go through them for those of you who are not. Hot flashes, very common, vaginal dryness, irritability, anxiety and depression, insomnia, fatigue, aches and pains, incontinence, poor short-term memory, and then risk of other diseases like Alzheimer's disease, osteoporosis, spine and hip fractures, loss of teeth, Wrinkles and dry skin, of course, increase. Cardiovascular disease increase. And cancers increase, notably breast cancer in women, prostate cancer in men. It's not a very encouraging list, is it? But a lot of these symptoms are very common. And I should say a lot of women present with as much with emotional disturbance as they do physical symptoms. And these are very often underestimated. Women will often be given antidepressants by their GPs for depression that they get because of hormone loss. In my book, they should be given their hormones back as a priority, and that would solve their depression in most cases. So we'll talk a bit about that a little later. So here you have some of the consequences of hormone deficiency in menopause. Now, what happens if you restore just estrogen? And I'm just talking estrogen here. Controls hot flushes, maintains pelvic health, improves cognitive function, improves mood, restores sleep, maintains thickness and fullness of hair and skin, protects against colon cancer, protects against macular degeneration, protects against or prevents atherosclerosis, hypertension, improves insulin sensitivity, prevents osteoporosis, prevents osteoarthritis, and improves memory. So lots of benefits. So, you know, you can understand why when a woman enters menopause, if they have very intrusive symptoms, that she may want to seek some form of hormone replacement, because not only is there symptom relief to be had, but also disease prevention and a lot of better aging benefits as well, which are very underestimated. Okay, so if we look now, this slide shows you the pattern of estrogen and progesterone change in a menstrual cycle in women. So what you see, and want you to know, the red curve is estrogen. You get a sort of follicular or pre-luteal peak, which you see on my arrow there. And then here's progesterone in blue. You see that progesterone really peaks in the luteal phase. These are the main two female hormones. Now I want to show you what happens. This slide, by the way, has reversed the colors. Sorry. Estrogen is now blue, just to confuse you. Progesterone is red. What you see here is on the left is the balance of hormones in the luteal or secretory phase of a menstrual cycle. See, they're in balance, aren't they? But when a woman goes towards premenopause or perimenopause, what you see is that estrogen dominates, progesterone falls, and it's typical for progesterone to fall sooner than estrogen. And here you have, in a woman who is sort of menopausal, again, what you see, estrogen has reduced, but there is still a relative imbalance between estrogen and progesterone. Okay, so I want you to note that. Estrogen and progesterone fall with age as you go into menopause, but the ratio, you can still have an estrogen dominance in a woman who is menopausal. Here you see testosterone declining with age, and you see that in women as well as in men, there is a decline in testosterone. But interestingly enough, when we address HRT from a conventional perspective, women are not generally offered testosterone, even though that also declines as estrogen and progesterone do. Now I want you to note this, and this is planting a seed for later, is what do we know about breast cancer rates with aging? We know, and this graph shows it clearly, that actually cancers increase in incidence with age. So just to plant one thought in your head, if breast cancer is hormone driven, why is it we see more incidence of breast cancers as we age and as the hormones are actually falling? That doesn't quite make sense, does it? If hormones are driving the cancer, you would expect to see actually a decline in breast cancer incidence with age. It's the same with prostate cancer in men. When testosterone levels are high in you, you don't see much prostate cancer. It's as men age that you see it more. So we need to explain this paradox, given what I've just said. But you see, I've put in the slide there, low or no progesterone may be something to do with it. That's an important point we'll cover in more detail in a minute. Okay, let's look at hormone replacement history. This is important. the story is very important here. Premarin was first, and now Premarin, the name, as some of you will know, is a horse urine derived estrogen. So it's from pregnant mares. So Premarin is how the name was derived. Actually approved in 1942. It's bioidentical for horses, not for humans. The first human steroid progesterone was synthesized in 1940. It's quite a long time ago, but it was absorbed poorly orally. Progesterone was then altered to make progestins, which are drug forms of progesterone. Hormone replacement uses molecules that have hormone-like effects. This is a very important point. Hormone-like effect doesn't necessarily mean having the same effect as the same hormones that your body produces. And we'll explain that more. The terminology, there's a lot of confusion over this whole thing. So HRT, hormone replacement therapy, ERT, estrogen replacement therapy, bioidentical hormones, what are they? Natural hormones. As far as the media and most of medicine are still concerned, you can lump all those together. They all increase risk. They're the same, they have the same negative effects, whether they're synthetic or not. That's nonsense, as I'll show you. Now, where did this ruckus all come from? Now, this study, which is based on the Women's Health Initiative study published originally in 2002, is where really the biggest fear and scare went out over HRT. Why was that? This is showing you the conclusion of the Women's Health Initiative study. And you see it there in the yellow bit, controlled trial, estrogen plus progestin. What did we find? After a mean intervention of 5.6 years and a mean follow-up of 7.9 years, breast cancer incidence was increased among women who received combined hormone therapy, right? And then the bit underlined, estrogen plus progestin was associated with greater breast cancer incidence, and the cancers are more commonly node positive, that's lymph node positive. Breast cancer mortality also appears to be increased with combined use of estrogen plus progestin. Now, progestin is synthetic forms of progesterone. Now, the other thing that the Women's Health Initiative study showed is the bit in green. There was also a 29% increase in risk of myocardial infarction, which is heart attack, or death from heart disease, and a 41% increase in risk of stroke, 200% increase in risk of thromboembolism, which are blood clots. So you can understand why, after this study was published, that a lot of women took themselves off HRT, even without consulting their doctors, because they were afraid of these long-term consequences. So the word that went out subsequently is HRT in any form is dangerous. It carries risks. We should be careful of it. Women shouldn't take it for more than 5 years because they would have increased risks after that. And that statement is still applicable to all forms of hormones, whether they are natural, bioidentical, or synthetic, as far as mainstream medicine is concerned. Now, Premarin, that horse-derived estrogen, alone given to older postmenopausal women causes adverse effects in the first year, like strokes and blood clots. That's not good. Oral estrogens cause blood clots, but transdermal estradiol, which is the main estrogen, does not. So there may be something in the way it's given as well as the form of the actual molecules that is important to this story. If you add Provera or Prempro or methoxyprogesterone, which is a progestin, you cause more adverse effects, breast cancers, heart attacks, and dementia. But when you add progesterone in its natural form, you do not see these adverse effects. Now, the statement of the bottom of that slide might be controversial to some, but drug companies are trying to confuse us all that all hormones are equally dangerous, and therefore we have to exercise exactly the same cautions as we do with synthetic HRT. All right, let's go on a little bit further in the story. Now, this slide compares andropause in men and menopause in women. And there are a lot of similarities in what happens with age. As the hormones decline, you'll notice body fat increases, well-being decreases, sexual function decreases, cardiovascular disease increases, osteoporosis increases. In men, prostate cancer increases, in women, breast cancer increases. So these are some of the commonalities in hormone decline. And it's not pleasant, is it, ladies? Because not only are there the sort of physical symptoms that you feel, the structural changes, you lose sort of tissue structure, drooping breasts, of course, the mood changes, low energy, headaches can be more common during menstruation, and vaginal dryness. And here this slide shows that, in fact, hormone replacement builds collagen. Women who are treated with hormones have higher levels of collagen in their skin than those in the green line you see there, versus women who are not treated. So we know that hormones build collagen in skin. This slide shows that the lower your estrogen levels, the greater the prevalence of sexual dysfunction, whether it's dryness, pain on intercourse, and burning, much more common when there is low estrogen. This slide shows that the benefits of hormone replacement in protecting against Alzheimer's disease. So what the graph on the right shows is that the longer that HRT is used, the greater there seems to be a protection against Alzheimer's. We also have, this slide just shows the benefits of transdermal estrogen, or estradiol. E2 is estradiol, and I'll come on to the different forms in a minute. So if you put estradiol, which is a form of estrogen, the main active estrogen, through the skin, this study showed that it significantly relieved perimenopausal depression. Here we see both estrogen and androgens increasing bone density. So we know that these hormones increase bone mineral density. All right, so that's just a quick run through some of the physical tissue benefits of replacing estrogen. I am going to talk about the other hormones, don't worry. But at the moment, I just want to focus and unravel this estrogen story and make it a bit clearer to you. So when we discuss estrogen, it's important to note that we're not talking about one molecule. There are actually three main estrogens in women. These are estriol, estrone, and estradiol. Now, the one most commonly known is estradiol. But actually, all three of these hormones women produce, they're all estrogens, and they all have physiological effects, different physiological effects, I hasten to add. So here this slide shows that estradiol is the predominant estrogen. It's produced in premenopausal women, whereas estrone is primarily the estrogen produced after menopause. In the body, estradiol is oxidized to estrone, and both estradiol and estrone can be converted to estriol. So it's a bit confusing, that, but really that's saying that the hormones are interconvertible, okay? The potency of estradiol, which is the main estrogen, is 12 times that of estrone, which is E1, and 80 times that of estriol. So these molecules which differ, they're all forms of estrogen, but they differ in potency. This is also extremely important because they don't all act in the same way or on the same receptor. Now, some of you may not have come across this before, so I will explain myself here. So basically, there are two main receptors for estrogen in the body. They are called alpha and beta. What we know is that estrogen receptor alpha, when that is stimulated, it promotes breast cell proliferation. But when you stimulate the estrogen beta receptor, it inhibits proliferation and prevents breast cancer development. Now, that's interesting, isn't it? Because what we're told is estrogens increase risk of breast cancer. Well, my response to that when people say that is, well, which estrogen are you talking about? As if you're talking about estradiol or estrone, or are you talking about estriol? Yeah, it's important to state which one you're talking about. So estradiol, this is interesting. Estradiol, the main estrogen, equally activates alpha and beta. And remember, alpha, breast cell proliferation, beta, it inhibits proliferation. Estradiol equally activates both, while estrone selectively stimulates the alpha receptor at a 5-to-1 ratio. Now you'll see that that's not a good thing. Which is the estrogen that's produced mainly in menopause? Estrone. So this differing stimulation of receptors may have something to do with the increased risk postmenopausally. The story is a bit more complex than that. Now, estriol selectively binds to this estrogen receptor beta at a ratio 3-to-1. And we've already established stimulating beta receptor is a good thing, modulates estrogen, it inhibits proliferation in the breast. So you can see just so far, not all estrogens have the same effect, and they don't all stimulate or increase risk of breast cancer. This slide is I always show it when I'm talking to doctors, and we may have some doctors joining us this evening. I'm not sure, but it raises a very interesting point. If you look at those two molecules, these are different forms of estrogen. On the left, you've got estradiol, which is a natural form of estrogen. This exists in the body, it's produced in the body. On the right, you have something called ethinyl estradiol. The only difference is this extra sidearm here. That molecule almost looks identical, you'll agree. Only difference is here. But look at the difference in effects between estradiol and ethinyl estradiol. Ethinyl estradiol cannot be inactivated by normal oxidation. It does not interact with estrogen beta receptor, the protective receptor. It is much more potent than estradiol, and it is more thrombogenic than estradiol. So, just a minor substitution, making that molecule synthetic, it's almost the same in appearance, completely changes the bioactivity of the hormone. So this notion that all hormones, all estrogens, whether they're synthetic or not, or natural, they all are the same, is absolute garbage. It does not match with what we know about biochemistry or what we know about changing molecules. Slightest change in a molecule can make it have completely different effects. Right, let's come back to Premarin. There's an important point on this slide. Different estrogens produce varying effects in different tissues. This can explain the problems with conjugated equine estrogens versus natural bioidentical. The main point is this next one. The major form of estrogen in Premarin, which is the horse-derived estrogen, the main estrogens are estrone. More than 50% of Premarin is estrone, which stimulates the alpha receptor. Equilin and equinolin, or equilenin, these are also foreign estrogens. They are bioidentical, as I said earlier, for horses, but they are foreign alien molecules to human beings. So there is a big distinction between when we're talking about natural estrogen in its form that's present in the body to what we're giving either in horse-derived form or synthetic form. But the majority of doctors think Premarin is mainly estradiol. It is not. Then there's the delivery of estrogen. So we have this difference in action according to which estrogen we're talking about, whether they're all the three of the natural ones or whether they're synthetic or not. But what about the delivery, how it's given to a woman? Well, if you give oral estrogen, it will elevate inflammatory markers, it will elevate clotting factors, it increases risk of blood clots, strokes, heart attacks in the first year. We know that. Whereas when you give transdermal estradiol, This mimics normal production and does not increase risk of blood clotting, and it doesn't increase inflammatory markers. So oral but not transdermal estrogen is associated with increased risk of clots. This is important. So giving oral estrogen to women is never a good idea, even if you give oral estradiol, which is or an oral form of natural hormone. The best route of delivery for hormones, estrogen I'm talking about, is not to give it orally. So most of HRT is still given that way, I'm afraid. And it has this complication of increased risk of clots. Oral but not transdermal estrogen, we've already said that. Micronized progesterone appears safe with respect to thrombotic risk. So if you add micronized progesterone, it doesn't increase risk of clots. Transdermal estradiol improves insulin sensitivity more than oral estradiol or estrogens. Transdermal estradiol provides normal estrone-estradiol ratio, while oral estradiol is heavily metabolized to estrone by first pass. So there's the other thing. When you take oral estrogen, you will break it down to the estrogen which is not favorable. So it's another reason, other than the clotting, to avoid taking oral estrogen. And it shouldn't be given orally. There are other better ways of giving it, either transdermally or submucosally. Now, just a couple of slides on estriol. This is important because the FDA, some of you may be aware, are trying earnestly to ban access to estriol. But let's look at it for a minute or two. When estriol is given together with estradiol, the estradiol-specific stimulation of breast cells is decreased. So it seems that estriol, when combined with estradiol, has a modulating effect on the effect of estrogen in general. Experimental studies suggest that estriol has a protective effect against radiation-induced cancer of the breast. In contrast, estriol, we've said that already, it binds, remember, to this beta receptor, which is favorable, whereas conjugated equine estrogens, which are the horse-derived estrogens, are potent downregulators of estrogen beta receptors. That means not only are they adverse in their effect anyway, but they actually downregulate the protective estrogen beta receptor. That's a double whammy. Whether this activity is unique to conjugating equine estrogen is unclear. It could potentially increase carcinogenic properties. Acting alone, estrogen, or estriol, sorry, is a weak estrogen, but when given with estradiol, it functions as an anti-estrogen. It modulates the effects of estradiol. Very important. During pregnancy, there's an approximate 15-fold increase in progesterone and 1,000-fold increase in estriol. So those two hormones go up significantly in pregnancy. And postpartum women, so after pregnancy, they continue to produce higher levels of estriol than women who've never had children. So this may be something to do with the protective effect that pregnancy seems to have on women developing breast cancer. Urinary estriol levels in postmenopausal women show an inverse correlation with the risk of breast cancer in many studies. So what does that mean? It means that the higher the levels of estriol produced, the lower the risk of breast cancer. So here we're talking about an estrogen, which when it's higher is favorable for breast cancer. It's completely the opposite of what we're being sold. An increased exposure to progesterone and estriol during and after pregnancy confers a significant long-term reduction in the risk of breast cancer. So there you see progesterone coming into the story. Estriol and progesterone, both which increase significantly in pregnancy, probably got something to do with lowering the risk of breast cancer from being pregnant. Okay, the FDA has not received a single report of an adverse effect of estriol in more than 30 years of it being used, and yet they're trying to ban it. Why, I wonder? Now, I just want to pause here for a minute because I know I'm sort of skipping over this pretty quick. Actually, on our website, I've written an article called "Not All Estrogens Are Created Equal." There's a lot more scientific reference in there. So if some of you really want to read more into this, go onto our website, go under scientific studies, and you can find this not all estrogens are equal, which is a decent summary. Alliance for Natural Health also published an article written by me on the same subject. So those of you who follow Alliance for Natural Health, you'll be able to find that feature article by me as well, if you're interested. Okay, before we leave estrogen and go on to progesterone and talk a bit more, this I want to show you, because the other side to the estrogen story is how the body breaks down estrogens. It doesn't all end with estrogen itself. This slide shows you that estrogen, and I'll summarize it. There are two main ways that estrogen gets broken down. It either gets broken down to these 2-hydroxy estrogens, which are thought to be safe and protective of the breast and of hormone-sensitive tissue, whereas these 16-hydroxy estrogens are thought to be not quite as safe. And the 4-hydroxy is worse because it's thought to be carcinogenic. So all women will break down estrogen down 2 main pathways. It's very easy to measure this in urine, and we often, more often than not, I do measure this in women who come to see me for hormones. It's important to know how a woman is going to break down, because if she's producing, because of her genes, an excess of toxic estrogens, the good news is that you can switch that nutritionally by giving things like cruciferous vegetables in the diet, indole-3 carbinol or DIM, which are both breakdown products of crucifers. And what they do is they cause a gene switch so that the pathways that produce safe estrogens are emphasized at the expense of the toxic estrogen-producing pathways. This is an example of how genes can be regulated, changed, manipulated by nutrition, by environment. So genes are not written in stone. They can be influenced by the things that they're surrounded by. Now, this slide shows you, in this case, 16-hydroxyestrogen, and this is from a woman who has, on the bottom right, you see staining for this toxic estrogen in the breast cancer tissue, but an absence of staining of this toxic estrogen in the surrounding normal tissue. It doesn't mean that we're not saying that this causes the breast cancer, but there's certainly an association between toxic estrogen breakdown products and the incidence of cancers. And so by changing that, if you measure it to be abnormal, that equates to doing something about their risk. All right, so I hope you're all with me so far, and I'm not going too fast. I want to talk a little bit now about progesterone and how that comes into the picture. I hope you're all clear on estrogen, the different forms of estrogen, the different effects, whether it's synthetic or not. It's very important. So progesterone, what does it do? It balances the action of estrogen, promotes thermogenesis, acts as a natural diuretic, aids thyroid function, helps stabilize blood sugar, normalizes zinc and copper ratios, and promotes proper cell oxygen levels. So it has profound psychological effect. Here on the left, you have a woman without progesterone, and on the right with progesterone. Now, I can tell you from experience that if a woman presents with sleeplessness and anxiety, usually that will be because she's deficient in progesterone. And I'm talking about menopausal women or perimenopausal women who generally have lower progesterone in relation to estrogen. That woman, you can transform her life by replacing natural progesterone, because it has this ability to calm the brain in women. That's what it does. It's a brain calming hormone. So lack of progesterone leads to more anxiety, irritability, hyperemotionality, hypersensitivity, nervousness, superficial and restless sleep, and loss of sex desire. So it's also involved in sexual satisfaction and libido. Now, the receptors for progesterone are found throughout the body. You see, we know that they're found for estrogen in the vagina, cervix, uterus, fallopian tubes, etc., thyroid and breast. Receptors for progesterone are also present in bone, central nervous system, white blood cells, lung, uterus, breast, colon, undoubtedly elsewhere. Now, a question to you. What are they doing there? If they were not designed to see progesterone, what are they doing there in those tissues? Clearly, the logical conclusion is that progesterone is meant to have an action in those tissues. However, there is still a policy in modern medicine which I completely disagree with, which is that when a woman has had a hysterectomy, had her uterus removed, and she needs hormone replacement, she only needs to be given estrogen. But then my question would be to that is, well, what about that woman's breast tissue? Doesn't that also need to see progesterone? But she still has her breasts. So you see, again, it's one of those insane things that we do in modern medicine without considering the complexity and the fact that these receptors are there and in these other tissues and should be seeing progesterone as well as estrogen. They're designed to see both hormones clearly. All right, now this is the progestin theater, the variability in these synthetic progesterones. They are not all progesterone, and the media and mainstream medicine have done a good job of trying to convince us that all progesterones, including progestins, are exactly the same. It doesn't matter which form they're in, they have the same effect. But as I've shown you with estrogen already, you can guess the same thing happens with progestin compared to progesterone. So here you see in blue at the bottom, progestins have androgenic, estrogenic, glucocorticoid, and progestational effect, depending on which progestin you're talking about. So clearly, they don't all have the same effect. Now, what about progesterone versus progestins? This is an important distinction. The Nurses' Health Study found that compared with women who never used hormones, use of unopposed postmenopausal estrogen from ages 50 to 60 years increased the risk of breast cancer to age 70 by 23%. When you added synthetic progestin, synthetic forms of progesterone, drug forms of progesterone, to the estrogen replacement, it resulted in tripling the risk for breast cancer. So what we know categorically is that when you combine a synthetic progestin with estrogen, this amplifies the risk of breast cancer. And I'll show you that in another slide in a minute. So patented drugs are not human hormones. I just want to interject here, okay? It should become clear to you that these patented molecules, this changing the molecule so it can be patented and make money, unfortunately, doesn't necessarily have the best health benefits for us human beings. It makes a lot of money for the drug industry, but it isn't necessarily the best combination when it comes to hormone replacement in women. The majority of doctors don't know the difference between these different forms of hormones, unfortunately. We're not really taught this at medical school, by the way. I graduated in 1992. I was never taught any of this at medical school. So I left there not knowing much about hormones or even knowing that there was any real difference between the different forms of hormones. Human hormones, of course, as they exist in nature, cannot be patented, and therefore there are no profits. That has a lot to do with why a lot of these things are not more widely available in the natural form. So here you see again a progesterone on the left. That's your natural progesterone. And look how similar this molecule, this form of progestin, this is methoxyprogesterone on the right here. It's a form of progestin, synthetic progesterone, that looks almost identical apart from these substitutions in red that you see there. They have completely different effects in the body. Progestins are often called progesterone in the media and in scientific papers, and it confuses everybody, including scientists and doctors. But here you see a contrast of the differing effects between progesterone and medroxyprogesterone, which is this Provera that I just showed you, the molecule I just showed you. So progesterone maintains pregnancy. That's one of its main functions, to maintain pregnancy. Progestation, that's where the name comes from. Whereas methoxyprogesterone causes birth defects. It improves mood. Natural progesterone can cause depression. Improves sleep. Causes insomnia and irritability. is diuretic, causes fluid retention, no effect on blood sugar, raises blood sugar, improves lipid profile, worsens lipid profile, no evidence of increased cardiovascular disease, can cause heart attacks, reduces estrogenic stimulation of the breasts, progesterone, natural progesterone, increased estrogenic stimulation of the breasts with synthetic progesterone, prevents breast cancer, can cause breast cancer. So you see, look, we cannot conclude based on this scientific data that all progesterones are created equal. They just aren't. So some more on the differences between natural progesterone effects that you don't see with synthetic progestins. So these next few slides just runs through very quickly some of the things natural progesterone does, but synthetic progestins don't. So studies have shown that progesterone does not induce estrogen-stimulated breast cell proliferation. Natural progesterone is protective against breast tissue. Now you see it in this chart here. This was published, this is nearly 70,000 women that were studied, published in 2005 in International Journal of Cancer. And what this slide shows is very interesting, as they studied women who had different forms of HRT. And here you have the control on the left. Here in this second bar is when you give estrogen alone, you see there's an increased risk of breast cancer. But when you give estrogen coming here, estrogen plus a synthetic progesterone, there's an increased risk of breast cancer, depending on the form of synthetic progesterone that you use. But what we want to note here in this column is that when you give estradiol with natural micronized progesterone, I beg your pardon, there is absolutely no increased risk of breast cancer. Now, this has been repeated in several studies now. So the notion that progesterones are all the same, nonsense. If you use the right form of natural progesterone with estrogen, there is no increased risk of breast cancer. That means you can give HRT to women over a period of time safely, so they get all the benefits, all the symptom release without the increased risks. But unfortunately, doing it like this is not being driven by the pharmaceutical industry or by conventional medicine thinking at the moment, I am afraid. Now here's another study showing the same thing, and the trend is the same, and it's this time looking at venous thromboembolism, so clots, and you see the same trend. Estrogen alone, not much difference, but when you combine estrogen with synthetic progestins, guess what happens? Massive increase in risk of clots. You don't see that when you combine estradiol with natural progesterone. You see, in fact, no change in the risk of clots. So, more effects of natural progesterone not seen with progestins, helps to balance estrogen, leaves the body quickly, improves sleep, natural calming effect, lowers high blood pressure, helps the body use and eliminate fats, lowers cholesterol. Increases scalp hair, helps balance fluid in the cells, increases the beneficial risks of estrogen on blood vessels, increases metabolic rate, is a natural diuretic, is a natural antidepressant, and is an anti-inflammatory, and as distinct from progestins. Stimulates the production of new bone, enhances the action of thyroid hormones, improves libido, helps restore proper oxygen levels, improves the conversion of estrone, which is the more adverse of the three estrogens, to a more inactive estrone, promotes Th2 immunity, it's part of the immune system activity, is neuroprotective, so protects nervous system, and promotes the formation of the coverings of nerves, the myelination. So there are lots of benefits of progesterone that we don't see with progestins. Now again, for those of you who want to read more about this, who want to see some of the scientific references, go onto our website, look under scientific papers. I wrote an article called "Not All Progesterones Are Created Equal." So for those of you who want more information, it's all there. How are we doing for time? Okay. All right, not too bad. We're coming to the end of the presentation, then I want to allow a few minutes to look at any questions that have been asked. By the way, I should warn you now, if any of you do have questions you want to ask, put them in the question and answer slot, and I'll have a look at those shortly and pick one or two of those out to answer depending on how much time we've got. Okay, so when it comes to this, talking about bioidentical hormones, and we've talked a little bit about those, we're talking about mainly estrogen, estriol, the two forms of natural estrogen. We tend not to use estrone when we give estrogen replacement to women when we use bioidenticals, because why give that third estrogen which has more negative effects? It's not necessary. You can still see all the benefits that we want without that. So that's why those of us who prescribe BHRT will often prescribe something called Biest, which is a combination of estradiol, but mainly estriol, which is the protective estrogen. We call it Biest for short. It was really Suzanne Summers that sort of flagged this whole difference between bioidenticals versus synthetic hormones. I don't know if any of you have read her book, but just to, she did a good service for the whole bioidentical movement, actually. This is a very pivotal paper by Kent Holtorf, published in 2009, where he actually he reviews the differences between bioidentical hormones and synthetic forms. This reference will be found, if you go on these papers on our website, you'll see the references to this paper. It's a very well-referenced paper, and referenced in the sense it has a lot of science in it, but also a lot of doctors refer to this because it really presents the arguments very well. Okay, what about pharmaceutical pressure? Well, this is interesting, isn't it? Because if you look at the American Congress of the Obstetricians and Gynecologists, they say compounded bioidentical hormones should be considered to have the same safety issues of those hormones products that are approved by the FDA. Hormone therapy does not belong to, etc., etc. Then what about the Endocrine Society in 2000? All estrogen-containing hormone therapies, bioidentical or tradition, would be expected to carry essentially the same risks and benefits of those products used in the Women's Health Initiative study. And what about the North American Menopause Society, 2008? The generalized benefit risk ratio data of commercially available hormone therapy products should apply equally to bioidentical hormone therapy. Now, it may be interesting for you to note that all three of those organizations are funded by pharmaceutical corporations that make profits on synthetic hormones. So doctors assume that when they see these statements by these expert organizations, that they're completely unbiased. And honestly, it's still, when I read it, and I've read this many times, it really unnerves me that this is what's being put out, and that this is convincing people that all hormones are the same. It doesn't matter whether they're natural or not. I've presented to you this evening data contrary to these statements, and I hope you'll take this on board. It's important. Now, in the last few minutes, last few minutes, I just want to talk a bit about testosterone and androgens in women, what they do, very quickly. Androgens are beneficial because they affect bone mass, they increase bone mass, they increase muscle mass, they improve well-being, mood, improve sexual function, maintain pelvic health, and improve insulin sensitivity. A lot of women worry about testosterone because they think, oh, well, if I take testosterone, will it increase my risk of breast cancer? There is no study which show that taking testosterone increases risk, quite the opposite. It's testosterone seems to serve as an endogenous protector of the breast, and it limits the activity of estrogen in the same way that progesterone does. Androgen action is anti-proliferative and pro-apoptotic. That means it encourages cancer cell death, despite the potential for testosterone to be converted to estrogen. So that's the concern. If I take testosterone, it does convert to estrogen. There's no evidence, in fact, that it increases risk of breast cancer. Quite the opposite. Testosterone reduces mammary estrogen receptor alpha and increases beta receptor expression. I already told you earlier how that's favorable, resulting in a marked reversal of estrogen receptor alpha beta ratio. And this study was really a sort of summary. Look at the conclusion. Predominant data shows that low-dose testosterone use is safe in regards to breast endometrium, with experimental data suggesting a decrease in estrogen-induced breast epithelial proliferation with no adverse cardiovascular effects. So we will often use testosterone replacement when we're replacing hormones in women if their testosterone is low, and particularly if they have low libido, it has the advantage of helping to build muscle and bone as well. Many benefits. I think this may be one of my last slides. Just finally, DHEA. A lot of anti-aging doctors will give this. It's the most produced hormone in the body in men and women. It's the first one to fall of the hormones. But look at some of the things that it does. It boosts energy. It's effective against stress. It improves sleep. It improves powers of recollection, strengthens the immune system, improves lean mass, improves insulin resistance, and improves sexual satisfaction. And again, this is another hormone that declines with aging, is not replaced usually from conventional HRT perspective. But doctors who replace with BHRT, natural hormones, will often consider giving DHEA, especially if it's at a low level when it's measured in the blood. Just hormones on skin, don't worry too much about reading all of this. The take-home message from that is that if you apply bioidentical hormones, including progesterone, estriol, topically on the skin, they actually build elastin and they build collagen in the same way as if you took them orally. So just to let you know, for those of you who are interested, I developed some face creams based on using natural hormones that you can put onto the skin and that actually help to have a real anti-aging collagen elastin building effect. And the data supports that they do that when they're applied topically. So summary, this is my last slide, and then I'll have a quick look at questions. We might be able to just pick off one or two of them. The popular view is that hormones in all forms are dangerous, and that's false. I think that's a point that I think I've made very clearly this evening. Not all estrogens are created equal. We've discussed that. Synthetic estrogens may tip the balance in favor of breast cell proliferation. This is less likely with bioidentical blends of estrogens, especially when estriol is combined with estradiol. And that's what we do. Not all progesterones are created equal. We talked about that. Progestins increase risk of breast cancer and risk of clots when combined with estrogen, but progesterone does not do either of those two things. Progesterone has a breast protective effect, doesn't increase risk of clots, and I just told you testosterone also seems to have an anti-cancer, anti-proliferative effect. All the evidence suggests that women can have hormone replacement therapy without the risks if hormones are administered correctly and in the natural bioidentical form. So, what have I just done? No, this is the last slide. It's just for those of you who want to get in touch. That's the email contact. I'm just gonna have a quick look at what questions that have been asked, and let me see if some of you can stay on just for 2 more minutes. I'm going to finish within the next sort of 2 or 3 minutes. Let me just see what questions have been asked. A question here: How long do you suggest a woman takes BHRT? Well, we don't have the same safety concerns that we do with synthetic hormones. So you can take BHRT as long as you like. It should be monitored. So all our patients that are on BHRT have at least an annual review of their hormones and a check that they're doing okay. That's proper monitoring. But we don't have the reservations of long-term replacement that we do with synthetics, because we don't see any increased risk of breast cancer, clots, or other adverse effects, is the answer. What are bioidentical hormones made from? They are made from plant sources, usually either soya or yams. That's the usual source. Now, some people say, oh, well, I can't take soya. But it's not soya that's left. By the time they take the molecule and modify it so it's identical to the ones we produce, there is no soya left. It's just that soya is the raw material that's used for the molecule before it's changed into the bioidentical form. I have a question here. I'm a menopausal at the age of 55, having a lot of negative side effects as listed. I have 2 sisters suffering with breast cancer and a maternal aunt making me higher risk of HRT. Will I be safe taking any hormones? Well, the answer to that is you will be safer if you take the hormones in bioidentical form, because we know that the combination of natural estrogen with natural progesterone does not increase risk of breast cancer. So the answer is yes, but you should still be monitored. And one of the ways of doing that without having a mammogram every year is to consider having a thermogram. Many of you will already know that that's another service that I offer. Just one more I'll pick because there are quite a few questions here and we don't have time. What tests would you give to test hormones? What tests, someone asked? That's a good question. Various doctors do different things. I personally test serum, so blood. In an ideal world, you would test urine as well as blood, because in urine you can see the breakdown products of the hormones as well. But it's too costly to do both all the time. I find, in my experience, that using blood is the best way of getting a gauge of what the levels are, and also you'll always monitor the patient results as well, or the subjective improvement. So you've got to balance out what you see in terms of blood levels with what the patient is telling you. Now, saliva testing is the other way that doctors can test it. I'm not a big fan of saliva testing for hormones. It's okay to start with if you want a baseline, but I think it overestimates the amount of hormones that are present when you're already on hormones. So I'm not a fan of doing it that way. Someone, last question. I have run out of estrogel. Is it safe to use Progesterone, progesterone, and testosterone alone to reduce symptoms until I can get more? Is it safe to? Yes, is the answer. You can use Progesterone and testosterone alone. There are no adverse effects of doing that. So if you were to do that as a temporary measure, that's absolutely fine. So I think I've got to draw this to a close, folks, because we are now at 7:32. It just remains for me to say, I'm sorry I couldn't answer all of the questions that have been asked, but I hope that my sort of quick guide through hormones and menopause has been really useful to you. This has been recorded. So as I say, if you please feel free, we'll send you the link to listen to it again at your leisure. If you feel that any of your friends, relatives would benefit from hearing it, then by all means pass on the link to them. Thank you very much for joining me this evening. Stay tuned to find out when we're doing our next webinar. You'll find that out in our newsletter, those of you who receive it. If you don't get our newsletter, then by all means send us an email and we'll put you on the mailing list so that you are notified of any future webinars that we'll be doing. All right, so thank you again for joining me this evening. I hope you've enjoyed this presentation and look forward to speaking to you again on a different topic soonish. All right, all the best for now. Take care. God bless.